Good morning. Students, this is Dr. Herndon. I'm going to be going with you through chapter 14. This is a chapter on depressive disorders, and it's very, very interesting. And a lot of medications in this chapter that you'll need to know. And but we'll get started. Okay, so here are your objectives. And so uh, Your objectives include identifying symptoms of disruptive mood dysregulation disorder, persistent depression disorder or dysthymia, and premenstrual dysphoric disorder. So there's a specific medication listed in your text that is especially designed and created for this particular disorder. So that's interesting. Another objective discuss the epidemiology of major depressive disorders, and then discuss the biological and cognitive risk factors for the development of major depressive disorder. So this is a very interesting chapter, and I chose to record this one first before chapter 13 because chapter 13 is a little bit longer. So I wanted to get this one out of the way and save the longest one for last. So, but I do look forward to seeing you on Tuesday. Okay, so these are the depressive disorders. All of the depressive disorders share the same symptoms, and these symptoms include sadness, emptiness, irritability, somatic or symptoms of just the body systems. And then, of course, patients have those concerns whenever they have a depressive disorder. You'll see that, and they'll complain. Some of their major complaints will be regarding those bodily functions and bodily symptoms. And then impairment of thinking. So they're going to be dulled. They're going to be slow thinking or dysfunctional thinking. So all of these symptoms impact a person's ability to function, of course. So, um, and then the classification of major depressive disorders. You have your major depressive disorders, and then you have others. Disruptive mood dysregulation disorder, persistent depressive disorder, um, and dysthymia, premenstrual dysphoric disorder. I spoke of that. Substance abuse or substance and medication induced depressive disorder. So we do have that. That is prevalent in our communities. We see a lot of that. We've spoken of this in other lectures. We've spoken that of the fact that sometimes we go onto the unit in the hospital, and everyone that we have in the hospital is there for either a substance use related uh, problem, or something has happened that has been uh, caused related to using substances. So it's very prevalent in our community. Um, Another one, depressive disorder due to another medical condition. So we do have hopelessness in people with chronic medical conditions or acute medical conditions that where they are hopeless. They have no hope to get better, and so that creates a depressive uh, a sadness within them that is there, and it needs to be they need to be cared for in that respect. So we do have a case study here. Jeff, 19, is brought to the hospital after a suicide attempt. His parents found him in his backyard wearing his favorite black jeans and black t-shirt but with one of his father's neckties, he had overdosed on some of his mother's pills, but his stomach was pumped in time. He has just been admitted to your floor for 24-hour suicide observation. So, talk about this slide. Just a second. So, disruptive mood dysregulation disorder. This is diagnosed in children, excuse me, ages 6 to 18, and the symptoms include constant and severe irritability and anger, and also temper tantrums out of proportion to the situation at least 3 times per week. And then they exhibit symptoms in at least 2 settings, including the home, the school, and with peers. So at least 2 of those. And so the management here is symptomatic medications, cognitive behavioral therapy. We've seen that a couple of times so far, and parent training and facial expression recognition training for the child, because your text explains that previous to this disorder being identified, children were being diagnosed with bipolar disorder, which they were medicated for, and then it didn't help, and it made matters worse. So so what they discovered was that children should not be diagnosed with bipolar disorder, because probably they will um, grow out of that, so to speak. And but usually, if they are diagnosed with this type of disorder, then they're probably going to have some sort of problem in the future, but it's not going to be bipolar. So so they developed protocol that would allow for cognitive behavioral therapy and other less intense therapy than the strong medications, which cause side effects, which cause problems in children. So and so they just treat the symptoms, and they have therapies that focus on cognitive functioning and training, because they found too that the children were kind of perceiving that people were angry at them, and so they needed training to identify the facial expressions of others. So that was very interesting. Um, so so that is the way that came about. And then this is persistent depressive disorder, and that was formerly called dysthymia. And this one is a low-level depressive feeling through most of each day for the majority of days. So at least 2 years in the adults is a criteria for diagnosis with persistent depressive disorder, and at least 1 year in children and adolescents. So they must have 2 or more of the following symptoms: a decreased appetite or overeating, also insomnia or hypersomnia. They either can't sleep, or they sleep too much. Low energy, poor self-esteem, difficulty thinking, and hopelessness. So, so those are the symptoms. They must have 2 or more of those symptoms to be diagnosed. And so this is something that is prevalent in our society. And so dis means when you look at dysthymia, it was formerly known as dysthymia, and that just means it's a dysfunction of mood. So the DYS means bad, and thymia means mood. So so really just a bad mood, persistent bad mood. Um, and so this feeling happens for most days in these individuals, and the symptoms are difficult for the patient to live with and bring out social and occupational distress, but they're not usually severe enough to require hospitalization. So they're treated, and it usually occurs first. The onset usually occurs in teenage years, and patients will frequently express that they have always felt this way, and that being depressed seems like normal to them. It is not uncommon for people with this low-level depression to also have periods of full-blown major depressive symptoms. So that's important to know. And the prevalence of persistent depressive disorder ranges from 1.5% to 3.3%. And this problem tends to have an early onset, and as the name suggests, it is a chronic illness. So it is more common in women, as most of these diseases are, and up to 50% of this disorder go undiagnosed and seek care for physical symptoms. And um, so somatic systems, they're seeking care for bodily dysfunctions, just um, different bodily dysfunctions. They're seeking the care of those symptoms, and they're not really getting to the bottom of what is really causing all of those symptoms. So it's just a really chronic issue, a chronic process that goes on with these. Um, so um, the treatment for this is really similar to that of major depressive disorder, and it includes psychotherapy, cognitive behavioral therapy. We've heard of that therapy a lot throughout Nursing 114, and it is quite useful in managing the symptoms. Antidepressants, such as selective serotonin reuptake inhibitors, um, serotonin and norepinephrine reuptake inhibitors, and the tricyclic are the other main treatments if it gets bad enough. If it's severe enough, then we can use those in medicine. The providers can prescribe those, but of course the SSRIs are the first line. Um, okay. Okay, so now we're at premenstrual dysphoric disorder, and the symptoms cluster in the last week prior to the onset of a woman's period. This is previously known as PMS, premenstrual syndrome, uh, and so it brings about symptoms um, such as intense mood swings, irritability all of a sudden in that 1 week, depression, anxiety, feeling overwhelmed, and difficulty concentrating. And these are real symptoms for women. And it's not something that they just dream up. It happens. It's usually uh, due to hormonal fluctuation. And it's actually due to a drop, a sudden drop in a hormone, and certain hormones, and the symptoms decrease significantly or disappear with the onset of the period, so the onset of menstruation. So that's what happens, and it is relatively a new this the what they call it is new. It's not new. It's always happened, but the name for it, the premenstrual dysphoric disorder, it is a new name in the addition to the diagnostic system for psychiatry, and it does refer to those cluster of symptoms that occur the last week before the onset of a woman's period. So this only happens in women, and the sometimes the problems are severe enough to interfere with the ability to work or interest with others. Or interaction with others, and sometimes it can be more severe in some women than others. And I have studied this, and previous to this job that I have now with you all. But what I found in my studies was that the women that were very active physically, the exercise, the physical exercise, physical activity did seem to help with this. And so it a lot of times the physicians and providers will encourage women to be physically active and increase their physical activity. So hopefully it can kind of curb the symptoms. Um, but unfortunately, some of the symptoms do include lack of energy, also overeating, which can cause bloating, which can cause women to feel like they don't want to have activity, have physical activity. Um, Also, it causes breast tenderness, aching, bloating, and weight gain. And but as I said, the symptoms decrease significantly or disappear altogether with the onset of menstruation. The prevalence of this dysphoric disorder is about 2% to 6% of all menstruating women, all women who have periods, and the symptoms cease after menopause, although they may return with hormone replacement therapy. So the treatment is, as I said, as I alluded to, it's regular exercise, particularly aerobic exercise, and other recommendations include eating food rich in complex carbohydrates and getting sufficient sleep. So sleep is so important. Um, Acupuncture has been used, light therapy and relaxation therapy also have all been used to reduce the symptoms. Now, several drugs have FDA approval for treatment of this disorder. A drospirenone and ethinyl estradiol combination is called Yaz. It's like a birth control pill, but it's called Yaz, uh, Giambi, and it is a contraceptive that improves the symptoms. So women can be prescribed that for this to kind of regulate the hormones and um, keep them kind of at a similar level all of the month, the whole weeks of the month. SSRIs have been used successfully, and 3 have FDA approval. And these SSRIs that are approved for this menstrual dysphoric disorder are fluoxetine or Prozac and Seraphim, also Zoloft or sertraline, and then the control release paroxetine or Paxil, CR, control release. And diuretics may be useful in reducing the bloating and the weight gain brought on by the water retention. Okay, so these are other depressive disorders, and they are substance-induced depressive disorder. And so we know that when people abuse drugs or they use drugs, there are side effects. And so it takes a while for these drugs to get out of their system. But after they've used the drugs, it tends to have a rebound. They're using the drugs to feel high, to feel elated, to feel good. But then they have a rebound effect where the person comes way down after they've used the drug. So it's hard on the body too. So everything is kind of out of out of the regular, out of the norm, and they have depressive disorders most times after they've used substances. And then also depressive disorder associated with another medical condition. Okay, so the substance and the medication-induced depressive disorder is a result of the prolonged use of or the withdrawal from drugs and alcohol. And these depressive symptoms do last longer than the expected length of the physiological effects or the intoxication or withdrawal of the substance. And the person with this diagnosis, excuse me, would not experience depressive symptoms in the absence of drug or alcohol use or withdrawal. The symptoms appear within 1 month of use. And once the substance is removed, the depressive symptoms usually remit within a few days to several weeks. The lifetime prevalence rate is fairly low, about 0.25%, and the medications associated with depressive symptoms include antiviral agents, cardiovascular drugs, retinoic acid derivatives, antidepressants, anticonvulsants, anti-migraine agents, antipsychotic agents, also hormonal agents, smoking cessation agents, and also immunological agents. So, and then your depressive disorder due to another medical condition. This may be caused by disorders that affect the body system or from long-term illnesses that cause ongoing pain. So that can be very draining on a person's body, and the symptoms are the same as the diagnostic criteria for depressive disorders. It's important to review medications being used for the medical condition to rule them out as being a causative agent. But there are clear associations along with the neuroanatomical changes with some disease states. So the prevalence rate for this in people who have suffered a cerebrovascular accident or stroke is high, and it's at 30% to 50% in the first year. So it does cause these symptoms after a stroke. Parkinson's disease, Huntington's disease, Alzheimer's disease, and traumatic brain injury are also clearly associated with depressive disorders. So neuroendocrine conditions such as Cushing disease and hypothyroidism are also commonly accompanied by depression. Just think about hypothyroidism. It slows everything down, and people do get depressed because their state of normal is forever changed. It's not going to be like it was. They're not going to feel as active as they're not going to feel uh, like doing things like they did before. They're going to be sluggish, and their body has changed because everything has changed. Their hair, their skin is very dry. Their hair is very brittle, and probably thinning. And so everything's a lot different with hypothyroidism. Once the patient is diagnosed with this, they do, of course, they do give Synthroid and other drugs to replace the thyroid hormone, but it's never quite the same. So other medical conditions that may cause depressive disorder include arthritis, back pain, metabolic conditions such as vitamin B12 deficiency, also HIV, diabetes, infection, cancer, and autoimmune problems may also contribute to depression. And there's a table, table 14.1, that summarizes the medical problems and substances that are associated with major depression. So you need to make sure on page 242 that you're looking at that. The table 14.1 is labeled medical conditions and substances and medications associated with major depressive disorder. So make sure you study that and know that. And as I said, the boxes are so important. And then there's the box for DSM-5 criteria. for major depressive disorder. And it says 5 or more of the following symptoms have been present during the same 2-week period and represent a change from previous functioning. At least one of the symptoms in either depressed mood or loss of interest or pleasure is required to have this diagnosis. And so really pay attention to that box. And then it continues on page 243. So there's 2 separate portions of that box. So make sure you recognize that, you study it, and you know it for your test taking purposes, and as well as just being a good nurse. You're building on your knowledge base. Okay, so this is just a slide that indicates that 5 or more of the following in a 2-week period are indicated in the diagnosis of major depressive disorder. Major depressive disorder is one of the most common psychiatric disorders. In 2017, it affected approximately 17 million adults in the United States, or about 7% of the population. And Substance Abuse and Mental Health Services Administration is the that's where this statistic came from. Major depressive disorder or major depression is characterized by a persistently depressed mood lasting for a minimum of 2 weeks. So if it's not going away in a 2-week period, then we get concerned. The length of a depressive episode may be 5 to 6 months. About 20% of cases become chronic, lasting more than 2 years. And while depression begins with a single occurrence, most people experience recurrent episodes. And people experience a recurrence within the first year about 50% of the time, and within a lifetime up to 85% of the time. So again, the box on page 242 is very important. This diagnosis will be discussed using the terms major depressive disorder, major depression, and depression interchangeably throughout the chapter. So just be looking out for that. But on the slide, you have symptoms, specific symptoms of weight and appetite changes, sleep disturbances, fatigue, just feeling tired, worthlessness or guilt, having that, loss of ability to concentrate, and recurrent thoughts of death. So that's a red flag. We have to assess for suicidal ideation, and as we know, risk for suicide is the priority nursing diagnosis if that pops up, and psychomotor agitation. And so you have 5 or more of the following in a 2-week period in order to diagnose with the major depressive disorder. So all of these are indicated in that 5 or more of the following. So those are the symptoms that lead to the diagnosis. Plus, at least one symptom is also either depressive mood or loss of interest or pleasure, which has a word for it, and that is anhedonia. So know the meaning of that word, anhedonia. And so these are this just kind of puts different symptoms or different findings and categories. With major depressive disorder, you will have persistent symptoms for a minimum of 2 weeks, but it could last for up to 6 months. And then the chronic may last for more than 2 years. And you do have recurrent episodes that are common in these patients. And then the symptoms may cause distress or impaired function. So some people function better than others with the symptoms, but some people cannot function at all with these symptoms. So it impacts their whole life and the lives of their family members. So the episode is not attributed to physiological effects. So these symptoms for major depressive disorder, it is not, they are not attributed to the physiological effects. And then an absence of a manic or hypomanic episode. So if we had a presence of the manic or hypomanic episode, then we would think of bipolar disease. But so we want to make sure it's not bipolar. So that's the item that we look at to differentiate that. The leading cause of disability in the United States is the major depressive disorder. And you can see that in just looking at the patients. So in the United States, about 17 million adults had at least one major depressive episode. And the number represents about 7% of all U.S. adults. And the prevalence of depression was highest among adult females, of course. And so the females were at 8.7% of all of the U.S. females, compared to 5.3% of all the United States males. Young adults 18 to 25 seem to be affected the most, with a rate of 13.1%, and having two or more races or being white results in higher rates of depression for some reason. And figure 14.1 provides a snapshot of the prevalence details. So make sure you do look at that. And then children and adolescents, because some symptoms vary by age and circumstance, depression in children until recently has been under-recognized. We now know that even infants can display symptoms of depression. And with this understanding, we are just beginning to get a realistic view of the epidemiology of depression in children. In 2017, about 3 million adolescents aged 12 to 17 in the United States had at least one major depressive episode. And the number represents about 13% of all adolescents. The prevalence rate is higher than that of adults, which is especially troubling since a youth onset carries a higher recurrence rate, setting the stage for lifelong periods of depression. Figure 14.2 provides a summary of the prevalence statistics in adolescents. And so, this is important. And figure 14.1 on page 244, and then figure 14.2 on that same page 244. Make sure you look that over and and be able to kind of sum that up and recognize that. It's not important the exact details of those tables, but it is important for the overall recognition of the incident in those groups. The older adults, although depression in older adults is common, it's not a normal result of aging. So the risk of depression increases in health as health begins to deteriorate. About 1% to 5% of older adults who live in the community have depression. So you're going to see depression in a lot of your patients that are not admitted to the hospital because of depression. But you're going to see a lot of depression in those patients. So the statistic rises to 11.5% of hospitalized older adults and 13.5% for those requiring home care. And so that's an important important statistic, just to realize that many of your hospitalized older adults are going to be experiencing the symptoms of major depression. Okay, so a disproportionate number of older adults with depression are likely to die by suicide. Okay, so we have a case study here. During intake, Jeff doesn't speak much, but his parents are able to list the following symptoms they have observed. They have observed weight loss and appetite changes, insomnia, fatigue, worthlessness or guilt, and loss of interest in his college classes, and even the online games he usually plays with friends. And they also call his symptom the constant sadness. So they have noticed this in Jeff. And again, Jeff is 19 years old. So I have a practice question here for you. So Jeff's parents have described his lack of interest in things he used to enjoy, like games with his friends and his classes, which he used to like. And this may be best described by the term, is it A, in independence, B, impotence, C, indolence, or D, anhedonia? So the answer here is D, anhedonia, because anhedonia refers to the an, which would mean without, plus hedon, which means pleasure. And so that together means inability to feel happy. So that is what we call his symptoms here. So that is an important word to remember for testing purposes, as well as just to be a professional in the field of nursing. So we have to be that needs to be in our knowledge base to adequately care for people who may have depressive episodes. So now we're going to look at the risk factors. Cognitive theorists believe that people may acquire a psychological predisposition to depression due to early life experiences, and these experiences contribute to negative, illogical, and irrational thought processes that may remain dormant until they are activated during the times of stress. So stress will be, present if these folks develop some of these symptoms. So the biological factors include a genetic predisposition. A first degree family member may have the same biological factors, so that could be investigated with your patient. Also, the biochemical factor being a stressful life event that would bring on this. So stress is very impactful too. Stress is very destructive, and we need to have coping mechanisms because we can't avoid having stress. We have good stress and bad stress. Planning a wedding is a tremendous stressor. It's a good stress, but it's hard on the body, and it can cause a lot of havoc. Also, a divorce is a bad stress. A death of a family member or of a close friend is a stress. Loss of a job is a stress. There are documents that you can pull up and look at where there are different life events have different degrees of stress, and I think it's like the top 100 stressors in a lifetime, and they count up for certain points, and then you add up the points, and if you have underwent or undergone some of these events in your life, then you add up those points, and there's a table or there's a legend to where if you have these many points to this many points, then you're high risk, and then it goes on to have different degrees. of risk, from high risk to low risk for having depressive disorders and that kind of thing. I will try to grab one of those and copy it for you all before Tuesday. Um, Other risk factors include hormonal risk factors, maybe hormonal imbalances. And this includes the hormones in the brain that make us feel happy. And so your text goes into some of that. So it's very interesting, very fascinating how that can play out. And then you have inflammatory processes that would be a risk factor as well. Um, Diathesis stress model, this is the interplay between genetic and biological risk factors, and then we have cognitive factors. Um, and cognitive theorists believe that people may acquire a psychological predisposition, as I said, to depression during the early life experiences, and this would contribute to the negative and illogical and irrational thought processes that will remain dormant until they have those stressors. And again, I will try to pull up that stressor document that will kind of give you more insight into how that works. And then these are more risk factors. Obviously, the female gender is more likely to have this because of all of the hormone fluctuations in the female. Also, adverse child experiences, as we just said, would factor in. Stressful life events impact greatly the risk factors for uh, this. And then neuroticism, um, people that are just seem to overreact or have a tendency to over dramatize um, everything that happens, whether it's a really intense situation or not. It's everything that they over dramatize. Other disorders such as a substance use, anxiety, and personality disorders. So you've studied personality disorders, so obviously those would impact. And then a chronic or disabling medical condition. So you can see how that would impact a person's life. And so here are some objectives that we'll focus on moving forward. Assess behaviors in a patient with depression in regard to each of the following areas: their behavior, their mood, their feelings, and their emotions, their thought processes, and their thought content, and perception of what's going on in their life. So, um, perception and attitude are so important in how we are able to thrive in our life and be resilient. So, and then we'll formulate 5 nursing diagnoses for a patient with major depressive disorder and include outcome criteria. And these are more objectives for this part of our slide presentation. We want to name unrealistic expectation that a nurse may have while working with a patient with depression and compare them to your own personal thought. And then hopefully we'll have time to role play 6 principles of communication that are useful in working with patients with depression. So that's important. So we need to have those skills in our skill set to be able to therapeutically communicate and therapeutically interact with our patients. And so this slide represents a nursing assessment. But first, before we move forward with this, I want you to take note on page 246 of a patient's PET scan, a 45-year-old woman with recurrent depression. The scan, it shows a comparison scan. It's a PET scan. positron emission tomography scan. And so we call that PET scan. I know y'all know what that is. But we look at that, we compare the scan during a depressive episode and following recovery. And so on page 246, and the scan on the left, when taken when the patient was on no medication and was very depressed, and the scan on the right was taken several months later when the patient was well after she had been treated with an antidepressant. And so what we want to note here is that her entire brain, particularly the left prefrontal cortex, is more active when she is well. And so that's just something that I wanted you to take note of, how medicine can help these individuals. Um, and so on page 246 too, it does go over what we talked about with the hormonal, the neurotransmitters and hormones that have the same receptors and pathways in the mood area of the brain. And the most widely studied neuroendocrine area in relation to major depressive disorders has been hyperactivity of the hypothalamic pituitary adrenal cortex axis. So people with depression have increased urine cortisol levels and elevated corticotrophin releasing hormone. Um, so that cortisol level that is increased causes a lot of different symptoms in the body, but it is indicative of how this depression is impacting the total body and just causing havoc within the body. So um, depression rates are almost equal for males and females in the years preceding puberty and in older adults, and this has led to more research into the effect of hormones on depression in women. So that is what I said earlier. Women are more susceptible in their adult life, and it's usually thought to be due to the hormonal fluctuation in women. Um, and research has found that estradiol, that is a form of estrogen, it affects receptors sensitive to serotonin in the areas of the brain responsible for the mood. Um, so they did the research in rats, but the thought is the theory is that it's transferable to humans, that information is transferable to humans. And as the relationships between sex hormones, such as estrogen in women and testosterone in males, are better understood, it is thought that more effective therapies may be developed from that knowledge. So it continues to be researched. Inflammation in the body's natural defense, it is the body's natural defense to physical injury, but there is growing evidence that inflammation may be the result of psychological injury as well. Research has focused on two important blood components related to inflammation. So those blood components are C-reactive protein. I know you've heard of that. You've probably worked with this in your lab, and your clinical preparation. You've probably seen this in the labs of the folks you've been preparing to care for. But that C-reactive protein and interleukin-6, those are important in relation to inflammation in the body. So in young females with a history of adversity, depression is accompanied by elevations in these blood components, but not in children without a history of adversity. So that's very interesting. Adversity in life may compromise the person's resilience and place children at risk for depression and other disorders. So that's important. And the social sciences studies, we study that with children who have had trauma in their early life or neglect or abuse. All of those things are important in children uh, because as they grow, those things will impact their health moving forward, and it stays with them for life. So that's important. And we know that if we suspect abuse or neglect, then that is reported. It's everyone's duty to report that, and especially nurses and medical professionals. So I just wanted to point that out. Um, we don't, they don't believe that inflammation causes depression, but the research points in the direction that it does play a role in depression. And a third of the people with major depression do have elevated inflammatory biomarkers in the absence of a physical illness. And people who have inflammatory disease have an increased risk of major depression. And finally, people treated with cytokines to enhance immunity during cancer treatment develop major depression at a high rate. Now, I think that having cancer would make you depressed, probably. But there is some evidence to suggest that anti-inflammatory agents can improve therapeutic effects of antidepressants that are being taken or prescribed. So I just wanted to point that out on page 246, and now we'll go ahead and but the nursing process and assessment on page 247 it begins, and so it talks about the general assessment. We do have some assessment tools, um, and they include the Beck Depression Inventory as well as a Hamilton Depression Scale. And then we have one especially made or created for geriatric patients. It's called the Geriatric Depression Scale. And so these scales are just an inventory, like a survey or a questionnaire, and they highlight predominant symptoms such seen in depression, and it is presented here uh, in your text, and it's really easy to use. These scales are, and they're usually done in the primary care setting and in the community settings. And you probably have had uh, some of these tools used on you. I know I've had them used on me when I go to my primary health care provider, and they are implemented in many settings, and it's just a screening tool um, to make sure that people are, you know, how to get a baseline on how their overall health in regard to depression is. And so administering these tools at a baseline and then you do it again periodically. This allows the clinicians to follow changes in the patient's symptoms and depression severity over time. And assessing suicidality is very important. Um, and excuse me. So this is going to be part of your role as a nurse more than likely. And there are examples of the depression screens on page 249. You have a patient health questionnaire 9, PHQ 9, and so you can look over that. And I'll try to make a note to make sure that we identify these scales in our epic as we move um, through our clinical rotations and see if they're implemented there. I haven't seen any yet in the past 2 weeks, but that doesn't mean they weren't there. It just means I haven't focused on that. Okay, so the self-assessment, patients with depression often reject the advice, the encouragement, and understanding of the nurse and others. They often seem unresponsive to nursing interventions, such and resistant to change. And if your assignment is to have a therapeutic interaction and your patient will not talk, you may feel like a failure. But when this occurs, the nurse may experience feelings of frustration, hopelessness, and annoyance. So depression, that is a hard diagnosis to interact with in regard to um, your patient in front of you, because they're going through a really tough time, and they seem to, don't want to open up, because it's just a very dark time, and sometimes they feel inhibited. Um, but if you use your therapeutic communication, I'm sure that they would be more open to discussing things with you, as a nurse. But on your slides, it talks about the best response for the nurse to embrace. And so we need to recognize that unrealistic expectations for yourself or the patient is not going to do you any good. It's not healthy. Um, and of course, we want to see the best outcome for our patient. We need to identify feelings that originate with the patient, and we need to understand the roles of biology and genetics play in major depressive disorders. So sometimes it's just going to be a tough situation that we can't always easily alter. So it's going to take many multidisciplinary professionals to treat this, and it's not going to be an easy fix like an antibiotic. But we do make a difference as nurses, especially our presence, just being there for them. Okay, so I have a question here for you, a practice question. Which question would be a priority when assessing for symptoms of major depression? And the first response is, tell me about any special powers you believe you have. B, you look really sad. Have you ever thought of harming yourself? C, your family says you never stop. How much sleep do you get? Or D, do you ever find that you don't remember where you've been or what you've done? So the correct answer is B. Safety is always the priority in assessment. So B says, you look really sad. Have you ever thought of harming yourself? So in people with depression, we do have to make sure that we're assessing their thought process for suicidal ideation. And if they are, then we need to, document that, and we need to respond to it. We need to let the providers know, and they need to be watching this patient very closely, because as we noted in chapter 25, suicide is a very dangerous, suicidal ideation is very dangerous, and we never know until we probe into that how far they've gone in relation to creating a plan. So we have to find out about that. And if they do have a plan, how lethal is the plan? And then we have to intervene. And there are guidelines for intervening. Most hospitals have protocols, or they're mandated actually to have protocols in place. And so this would be our highest, if we find that a patient is having suicidal ideation, the risk for suicide, nursing diagnosis will be our highest priority. And so this all kind of overlaps within these chapters that we're studying. And the nursing diagnoses, some of these, as I said, the first one will be risk for suicide. Safety is always the highest priority. Also, chronic low self-esteem, imbalanced nutrition. Also, constipation may be one. Disturbed sleep pattern may be another. Ineffective coping may be another. And disabled disabled family coping. So, so all of these nursing diagnoses are very important, and these are just some that could be utilized if your patient has a depressive or major depression. Okay, so outcome identification, we need to have outcomes that would be the opposite of what our nursing diagnoses included. Um, and it's important on the page 253. We do have a table 14.2 that will give us an organized uh, system of signs and symptoms of the patient, and then their nursing diagnoses are in the middle. They include those that we just spoke of, as well as more. Um, so you have a lot more there than I listed on your slide. And then on the right side of that grid, you do have the outcomes that you can look over that would be um, the correct outcomes that you would want to see. They are just the opposite. So for risk for suicide, you have decreased suicide risk would be the outcome. Expresses feelings, verbalizes suicidal ideas, and refrains from suicide attempts and plans for the future. And as I said in chapter 25, talking to the patient about their suicidal thoughts will not encourage them to commit suicide, just the opposite. We may think that it would, but just the opposite is true. We want to bring that information out so it will make them know that that is out in the open and they can talk about it, and they'll just have a free reign, freedom to talk about it. They'll know that they're free to talk about it, and that actually makes them better. So just know that. Um, and so table 14.2 on page 252 is what I want you to review and understand and know. And then there is a recovery model. Um, and I want you to look at page 255. It's very, very important. It's just really a review of your anatomy and physiology, but the neurobiology of depression and the effects of the antidepressants that we use. Um, I want you to look at this figure on page 255, and know about those, because those are very important. It goes down the list of the antidepressants that are used. We've already been through, uh, examining some of these medications in other chapters, but I want you to nail it down here and understand um, what these medications are good for. Uh, and know that all medications that are listed here have a similar efficacy, and they are chosen by their safety profile for the patient and their side effects. We wouldn't give a patient a medication that would have a really bad side effect for them in regard to what they're experiencing already. So I'll have a delayed response, and remember, they have a 2 to 3 week delay. So you would not expect these medications to work right away. So if you have a patient that is really having an intense depressive episode, they may try something different while the medication is being, we're waiting for that medication to kick in. So one of the things that later on in chapter 14 that you'll learn about is the electroconvulsive therapy, and sometimes it may be necessary to use this therapy on patients that are really severely impacted by, excuse me, the depressive episode. So if they're having an intense depressive episode, you may see this used. I have never seen this used, but I suspect that this would be used in a specialty hospital for a mental health problem. Excuse me. We do have some hospitals that specialize in mental health disease processes or uh, mental health disorders, such as depressive disorders. And so this would probably be more often used in those hospitals. But um, the electroconvulsive therapy is discussed on page 263, and you do need to know about that. Um, and so the pharmacotherapy is very important. And that pharmacotherapy is organized very concisely on page 255. And then also on page 256, you have table 14.5, interventions targeting the vegetative signs of depression. And so that's very important as well. And then on page 257, the genetic testing for more precise antidepressant selection. That's very interesting and important. Um, I do want you to pay attention to the term serotonin syndrome um, on page 257. This is one rare and life-threatening event associated with the selective serotonin reuptake inhibitors. The syndrome is thought to be related to an overactivation of the central serotonin receptors caused by either too high a dose of or an interaction with other drugs that are being used. And the symptoms are many, but some include severe abdominal pain, diarrhea, sweating, fever, and tachycardia, also elevated blood pressure, altered mental state, and that includes delirium, and then myoclonus or muscle spasms, and increased motor activity. They have irritability, they have hostility, and they have mood change. And severe manifestations can induce hyperpyrexia, and especially high fever, and cardiovascular shock, and death could occur. So I want you to know about that syndrome. It's called serotonin syndrome, and it's related to the SSRI use and possibly an interaction of other drugs along with the SSRI. And that is discussed on page 257. Okay, so we're looking at the nursing process continued, and of course we just have our planning, and planning would include the use of those pharmacotherapeutic drugs. It also would include health teaching and health promotion. Um, I want you to note on page 254, in the box at the top, it's called Considering Culture, Depressive Symptoms and Medical Errors in Physicians. I want you to read that box, and it's very, very interesting that it talks about medical errors and prevention of those medical errors. And it talks about physicians when who screen positively for depression are at a greater risk of committing those errors. And they have found that physicians who make errors were also more likely to have depressive symptoms um, for many months after that event. They feel remorse. They feel intense remorse about the errors that they make. And so we're trying to prevent these problems, but compounding this problem is a reluctance for physicians to seek treatment for major depressive disorders because once they do, um, that stigma is there. And many state medical boards are required applicants to report any psychiatric treatment, and this practice resulted in people hiding their conditions and also avoiding mental health care. So this is not what we want. We don't want them to avoid mental health care if they're having an issue, but they are hiding it because of fear of repercussions. But they call for organizational interventions aimed at reducing physicians' depressive symptoms, and they also highlighted the need for institutional policies to remove barriers to delivering evidence-based treatment of physicians with depression. So that's important. That could cross over to nurses, um, in some instances. So we want to look at that. But we do have health teaching and health promotion as, part of the planning for our patients with depression, and promotion of self-care activities and teamwork and safety. So we have to make sure that, also want to make sure that nurses don't experience burnout. And safety does become the most important issue facing a team that cares for the people with depression who may be at high risk for suicide. And of course, suicide precautions are usually instituted and include the removal of all harmful objects such as sharps. This includes razors, scissors, and nail files, and anything that could cause a strangulation risk, and any medication that can be used to overdose. So again, I know I've talked about this earlier. Some patients will hoard medications, save them in their cheek, collect them, and then use them to overdose once they've collected a bunch of it. So we have to check on them. If they're on suicidal precautions, we have to check on them every 15 minutes, or even have a one-on-one sitter in the room with them for observation. And I've seen y'all look in their mouths and make sure they swallowed that medication, not with depressive patients so far, but just in general. I like that. I like seeing that you're doing that. Um, and of course, all the nursing process and planning is geared toward the patient's phase of depression, and also particular symptoms, and also the patient's personal goals. So we include the patient in the planning. And then in the implementation, there are phases, 3 phases: the acute phase, 6 to 12 weeks, the continuation phase, which is 4 to 9 months, and then the maintenance phase would be 1 year or more. And your text has a lot of information in regard to these phases. And just note that I want you to make sure that you look at the implementation of the nursing process. And that would include the promotion of self-care activities and teamwork and safety, as I said, health teaching and health promotion. I think I said that when we were planning. But anyway, all of those would be included. And then of course, we would use counseling and communication. And health teaching, I already said health teaching and health promotion, promotion of health self-care activities and teamwork and safety. That's always a big piece to everything, because we can't do everything as nurses. We have to have other nurses on board, but we also have to have the physician, social workers, just a good spread and variety of different disciplines, multidisciplinary approach. The evaluation, of course, will be tailored to each patient's unique presentation. The basic self-care, the thought processes, self-esteem, and social interactions are all important for evaluation. Of course, your communication techniques are so important. We need to use simple, concrete words, allow time for a response, listen for covert messages, hidden messages, ask about suicide plans, and avoid platitudes. So we need to get on the patient's levels, on the patient's level, and just really use that good therapeutic communication. When a patient is silent, um, we need to make observations to reinforce reality and avoid direct questions to them when they're silent. Um, and just, of course, you know that just being there, making yourself present for the patient, offering self, that is an important aspect to care for the patient who has major depression. This slide just talks about the evaluation piece again. We've already said that this evaluation is tailored to each person, each patient's unique presentation, and it includes basic self-care, thought processes, and self-esteem, and social interactions. And next, we'll have our objectives. We want to identify the major classifications of antidepressants and general advantages and disadvantages of each. I think I've already made you aware of the diagram with the different pharmacotherapies um, in the chapter, and the fact that they do not work right after they're prescribed and administered. It takes up to 3 weeks or more for them to kick in, at least 2 weeks, but maybe 3 weeks or more. But objectives here are to identify the major classifications of antidepressants and discuss brain therapies for major depressive disorders such as electroconvulsive therapy. I did mention that already, and vagus nerve stimulation. So you need to go to that part of the chapter and really make sure you know those, because as I said, because the pharmacotherapies do not work right away, certain patients may need those therapies to be incorporated or, part of their care before those drugs start to work. Um, so in choosing an antidepressant, we need to look at their symptom profile, uh, for the patient, the side effect profile. Um, if the side effect includes sexual dysfunction and weight gain, is that going to be a major problem for the patient in front of you? Also, ease of administration and history of past responses. They may not respond well to some of these drugs. And then safety and medical considerations are always used. And again, on page 255, this kind of gives a good overview of how these drugs work inside the brain and the different drugs that are used. And then I would encourage you to know this page 255, and all of the text in the all of the information in the text corresponding to that. Okay, so in choosing an antidepressant, you would have to consider all of these factors on this slide. And then this slide just goes into antidepressants. The SSRIs are the first line, as you know. We've talked about this before, and they have a rare risk of serotonin syndrome. We've talked about what serotonin syndrome is, and I gave you the page number for that. When you do need to know that. That is an important rare condition that sometimes it comes about from using the SSRIs, but it's on page 257. Again, you need to know that. So serotonin norepinephrine reuptake inhibitors, the SSRI may be tolerated better than these. because these do have more side effects. I want you to read about these. The tricyclic antidepressants. These are anticholinergic. They do have adverse reactions. Sometimes when patients are on these for a long time, they do have irreversible symptoms that appear. So usually doctors, providers will not keep patients on these for that long. There's usually a guideline for this to avoid the tardive dyskinesia side effects that could occur, the jerking movements and their involuntary jerking and shaking movements that could occur due to the use of these. And they are thought to be irreversible, so you would not want to keep a patient on these drugs for that long. And then your monoamine oxidase inhibitors, and these are effective for unconventional depression. You have to monitor the diet closely with these drugs because a lot of foods have these have certain components in the foods that would uh, make this drug more intense for the patient. And there's a table 14.7 on page 261, that will guide you in understanding foods that contain tyramine, which can be dangerous for patients that are using monoamine oxidase inhibitors. So I want you to look at that. It includes certain vegetables, certain fruits, certain meats, sausages, fish, milk products, all cheeses have this substance in there. So you would have to, look at the foods that have little or no tyramine and advise patients to eat more of those foods than the other foods. Beer and wine are usually contraindicated for people who are using this drug because it has a lot of thiamine content, high thiamine content. Uh, Excuse me, I'm saying that wrong. It's tyramine content. So we have to monitor the diet of people with using these uh, MOI drugs. And then foods that contain other non-tyramine vasopressors include chocolate, fava beans, ginseng, and caffeinated beverages. So I want you to look at that table 14.7. I want you to look at box 14.5, drugs that can interact with MOI drugs, and know that because that's important. Um, and the good news is that these drugs are they are definitely not the first line drugs that are used with depression, depressive disorders. But they're probably the last drug that would be used. So that's a good, um, the good news in this, that you don't have to, look for this too often and monitor this too often. But if you worked in a mental health facility, you probably would. Um, Page 262, box 14.6. This is a patient and family teaching for the MOI drugs, and that's important. This slide just goes over the newer antidepressants that are used. And so I do want to point out that the Zulresso drug, the brinaxolone, the bottom drug here on this slide, it is the first and only FDA-approved medication specifically for postpartum depression. That is very important that you know that. It's ketamine. This is a methyl aspartate receptor antagonist, and it is a newer drug for um, for depressive disorders and major depressive disorder. So that's a stronger drug and a newer drug. The newer antidepressants are serotonin antagonists and reuptake inhibitors, the SARIs, and then the norepinephrine dopamine reuptake inhibitor, the NDRI, and then the noradrenergic and specific serotonergic antidepressant, NASSA. So those are the newer antidepressants that you can review in your text. And I would say the bottom two are most interesting. Okay, so here's a practice test question. Jeff was just diagnosed with major depressive disorder. Which medication is the healthcare provider most likely to start the patient on? So is it SSRIs? Is it B, SNRIs? Is it C, tricyclic antidepressant? Is it D, MOI? So the SSRIs are recommended as the first-line therapy. We've talked about this in multiple chapters. So it is the correct answer is A. And these are used as the first-line therapy for most types of depression. Examples of these SSRIs include Prozac, Zoloft, Paxil, Celexa, Lexapro, and Luvox. And so their generic names are in your text as well. So I'm going to let you review that, but you need to know these drugs. I would say these drugs are the most common drugs that will be used for depressive disorders. And then this is a case study discussion. Plan patient and family education to discuss what side effects Jeff might experience on his new medication regimen. Well, we'll talk about this in class, but this may include you may have to teach the patient and the family about the drugs that may induce agitation. They may induce anxiety, may induce sleep disturbances, tremor, sexual dysfunction, or tension headache. And the sexual dysfunction would be called primarily, it would be called anorgasmia. So that is the inability to have an orgasm. So that is what sexual dysfunction would mostly comprise of, be comprised of. And the effect of the SSRIs on sexual performance may be the most significant undesirable outcome reported by many patients. And then the autonomic reactions would include the dry mouth, the sweating, the weight change, the mild nausea, and the loose bowel movements. All of these may be experienced with the SSRIs as well. And then these are other treatments for depression. You may have a supplement called St. John's wort that could be used. If the patients are using this, though, they need to let their providers know that they are using this, because it may act on the other medications that are being prescribed to impact the effect. It may impact it, causing the drugs that they are being prescribed to be more potent or less effective. And then the brain stimulation therapies do include the electroconvulsive therapy, which I mentioned earlier, the ECT. This is discussed on page 263. Also, the repetitive transcranial magnetic stimulation, which is called also seen as RTMS. That is also discussed in that area in the section on 263 and 264. Other therapies include the vagus nerve stimulation and the deep brain stimulation, and then the light therapy and exercise. And as I told y'all time and time again, exercise, just general exercise, normal, regular exercise, aerobic exercise, it does create a feeling of well-being. And if the patient is able and the doctors recommend it, which most of them will, then that is a very good thing that patients can do for themselves. And but all of your other treatments for depression that I just mentioned and that are on this slide, they are in the area of page 262 through 264. So I want you to read that and make sure that you know those therapies. And this is just a slide that is related to the use of St. John's wort. St. John's wort is, it's derived from a flower that's processed into tea or tablet. It's thought to increase serotonin and norepinephrine and dopamine in the brain. So those are your feel-good hormones in the brain, or hormonal and chemical components in the brain that make you feel good. And it is useful in mild to moderate depression. But again, we need to let the physicians know if the patient is taking this. And then this just goes over electroconvulsive therapy. It is the most effective depression treatment. Does have a psychotic, it is for psychotic illnesses, second most common indication. And the electroconvulsive therapy is a primary treatment in severe malnutrition, exhaustion, and dehydration due to lengthy depression. So it's going to be used with very, very sick patients, patients that are just very impacted by their depression. Also, it's safer than medications with certain medical conditions, and it is used with delusional depression. So I would really study this slide because you may have a test question either on your next test or on your NCLEX exam after you graduate that you may have to pick out the uses of this therapy. And also, it's used for failure of previous medication trials. So if nothing else is working for the patient, they may try this. And then it's also used for schizophrenia with catatonia. So catatonia is when they're in a catatonic state. They're not moving. They're not hardly even blinking their eyelids. They're not able to move or communicate at all. So read your text about this. That's very important to read. And then this repetitive transcranial magnetic stimulation. It is non-invasive. It uses MRI strength magnetic pulses to stimulate focal areas of the cerebral cortex. It is used in the presence of metal. In the presence of metal, it is contraindicated. It cannot be used if they have had trauma and have required a metal plate to be placed in their brain or in their head. So the presence of metal is contraindicated with this. The adverse reactions include headache and lightheadedness, no neurological deficits or memory problems, and seizures. They rarely occur. Most are mild and include scalp tingling and discomfort at the administrative site. So those are the adverse reactions that could occur with this. And then for the vagal nerve stimulation, It was originally used to treat epilepsy. It decreases seizures and improves the mood. The electrical stimulation boosts the level of neurotransmitters in the brain, and the side effects would include voice alteration at nearly 60% of patients, and then the neck pain could happen with cough, paresthesia, and dyspnea, which tends to decrease with time. So those are your side effects of that. And then the deep brain stimulation, this is a surgically implanted electrode that is placed in the brain, and it stimulates those regions identified as underactive in depression. It is more invasive, of course, than the vagal nerve stimulation, and the electrodes are placed directly into the brain. The light therapy is a first-line treatment for seasonal affective disorders, or SAD. The efficacy due to influence of light on the melatonin is important. It is effective as medication for seasonal affective disorder, or SAD. And this is just when people become depressed during certain months of the year, like January and February and March. And it has a negative effect. The negative effects of this therapy, it could produce headaches and jitteriness. So that could be a part of that. And then for your exercise, this is a biological and social and physiological effect, has physiological effects, has a effect of just feeling well. And it increases the serotonin availability in the brain, and it dampens the HPA axis, which is thought to be overly active in depression. So I want you to look up the HPA axis. It involves the hypothalamus, the pituitary, and the axis of those two organs. But I want you to read about that. And then advanced practice interventions. We know that nurses who are advanced in their education, they have advanced degrees, they can perform psychological therapies, including the cognitive behavioral therapy, the interpersonal therapy, the time-limited focused psychotherapy, and the behavioral therapy, and as well as the group therapy. So mental health nurse practitioners or nurse practitioners who are trained as their focus is on mental health, they can provide these therapies for the patients, and many times they do. And then this is your question here. A patient with major depression walks and moves slowly. Which terms should the nurse use to document this finding? Is it psychomotor retardation? Is it psychomotor agitation? Is it vegetative sign? Or is it anhedonia? Well, the answer is A. It is psychomotor retardation. That's what it's called. So I want you to think about examples of assessment findings associated with all of these distractors in this question, because we may talk about that on Tuesday. And then your final question here, which assessment finding in a patient with major depression represents a vegetative sign? Is it A, restlessness, B, hypersomnia? Is it C, feelings of guilt, or is it D, frequent crying? Well, the answer is hypersomnia. They sleep too much. So that is B. And I want you to look at the other distractors in this question. And I want you to think about other vegetative signs associated with depression. And these may relate to grooming and hygiene deficiencies, significantly reduced appetite, changes in sleeping, eating, elimination, and sexual patterns. So there's a table, table 14.2, I think I've already identified that table for you, but I want you to look at that table and be ready to discuss that on Tuesday. I'm looking for, okay, so it's on page 252. So I want you to look at that table and be ready to discuss some of these on Tuesday. I'll look forward to seeing you, and I hope this video presentation is helpful. Thank you so much.